I'd like to show and share our experience of the use of P64 flow diverter stent in our practice.
Появилась фактически мы, по крайней мере, начали работу с этим стентом в 2016 году. Но на сегодняшний день, как вы знаете...
And today we have a series of these devices available on the Russian market. And the latest is P64. This stent is made of nitinol threads. And there is a range of devices available that and we can choose the necessary size depending on the morphology. So since 2009, we started treating aneurysms using flow diverters. So by now we have treated 649 patients. That means 849 patients, 895 aneurysms and our patients are of different age groups since 12 to 78 years old, or from early age till senior age. And here you see the results of the study. Conducted from September 2016 to 2020, and you can see that female predominant in this population. Maybe the reason is that women are more attentive to their health, and whenever they have experienced any problem, they go to see a doctor, and that's why we see more of this findings in women than in men. And the ratio is 1 to 5.5. So this was the result of the study for patients who came from the regions with ruptured aneurysms, and they required flow diverters. We had 5 patients with previously failed clipping, and we prepared the patients according to the standard protocol. We performed gastroscopy as just a regular, usual standard, like in cardiology, for example. We use double antiplatelet therapy. We don't use Plavix, usually because in institutions, in medical institutions, we usually use clopidogrel because it's cheaper, because we need to organize a tender. But clopidogrel is cheaper but less effective. That's why now we use ticagrelor. We use usually before the intervention we use 180 milligrams, double the dose, and we use it together with aspirin, 325 milligrams, and we always perform platelet function testing in patients. We use PFA 200 by Siemens and verify now that we've been using for the last 1.5 years. And as for sensitivity, if we measure the sensitivity and send patients to the treatment and intervention if we have the necessary results. We use introductory guide, introduce sheetless. And as for microcatheters, Excelsior XT27 and Headway 27. This is the distribution of the stents that we've been using for the last 10 years. P64 amounts to 1/3 of all stents that we use. As for the localization and size of aneurysms, usually we treat anterior circulation aneurysms in 90% of cases and posterior circulation aneurysms just in 10 cases. And most of our patients are patients with large and giant aneurysms, which constitute the most difficult class of aneurysm. And in which stents are the first line therapy. As for the results, we have 0 rate mortality, but we had some complications, usually associated with technical issues and problems. Those who tried flow diverters, there might be a problem with deployment and opening of the stent. And in proximal parts with markers, stents tend to close and collapse, and that depends on how you work with the stent. If we talk about Excelsior, which is if we talk about P64, which is not very rigid stent, and if there also might be a problem of detachment of the stent. So as we gained some experience, we also used Sophia catheter to decrease the mechanical impact on the zone of deployment. And if there is a problem with opening of the stent, we can always use a balloon or use a guide wire. But if P64 does not detach, it creates a big problem because we cannot open the stent. Depending on the morphology of the feeding artery, we faced problems too when the aneurysm had a wide neck and we tried to open the stent. The optimal sizes that we see in technical characteristics were a little bit different, and it could lead to migration of the stent due to wide neck of the aneurysm. So we need to determine the length of the stent carefully, so in order to avoid migration. As for clinical properties, the most complications were associated with neurological deficit. 3 cases, one case of hemorrhage, and visual impairment happened in this case of subaryoncoid hemorrhage. Unfortunately, we do not have an automatic robot arm in Russia available. That's why we are stuck with what we have. And in Philips, we have an option of modeling the anatomy of the aneurysm and the vessels. And here you see the plan of stenting. And you see the red mark. This is where we plan to deploy a stent. And it's also very important to see on control images whether the stent is fully open. And for that, we use a program of high definition CT, which gives us this images and helps us see if the stent is fully open. What happens if the stent does not open? We see stagnation of the contrast, especially in the sac of aneurysm. It's sometimes difficult to assess because we see the result of remodeling using flow diverted 6 months after the deployment of the stent, and some remnant is normal. And according to our experience, rapid thrombosis of the sac of aneurysm can lead to the rupture of aneurysm. In case of giant and large aneurysm, we can see significant stagnation of the contrast. And in the vessels, we see less stagnation. And in small aneurysms, we don't see any changes in hemodynamics. So what did we face just lately? So this is unruptured asymptomatic ophthalmic ICA aneurysm. And we placed a stent successfully. We use antiplatelet therapy, which was efficient. And in just a couple of minutes, we see thrombosis and stagnation inside the stent, stagnation of the contrast. And we had to retrieve the stent. It was a difficult manipulation. We used micro guide wire to put markers and then anchor using the loop retrieve the stent. We don't know why the thrombosis happened. Maybe in many cases, we don't know exactly the hemodynamic, the full hemodynamic picture in the patient. Hemostasis is important. We reoperated this patient 5 days later, and she received a more aggressive antiplatelet therapy, and we managed to place the stent successfully. So long-term results of our study, permanent neurological deficit, happened in 2.2% of cases in 3 patients. These patients had giant aneurysms. One patient died because of the rupture, supposedly because of the rupture of aneurysm and the following hemorrhage. we use CTA to control and to do the follow-up for the follow-up. And in some cases, we use cerebral angiography just to make sure. Total aneurysm occlusion rate in the period from 6 to 12 months was 88%, which corresponds to the literature, and and they correspond to using other devices too. So another case, a female, 49 years old, a symptomatic ophthalmic ICA aneurysm. We did coiling and placed a P64. And in 6 months, we see total occlusion of the aneurysm. We face large aneurysm with platelets in the lumen and in the sac of the aneurysm. So this is the angiography after flow diverter deployment, and according to MSCT, all cerebral vessels are patent, and we need to follow, but the size of the aneurysm is the same, and we need to follow the hemodynamic of the patient. So this is another case. Maybe we should have placed, this is a follow-up of this case, and maybe the reason that we had those problems is that we should have placed the stent a little bit further. Another case, a female, 63 years old, large aneurysm of left vertebral artery. Pica arises from the sac, and we use a flow diverter, which straightens according to the size of the artery where it is placed. In this case, the aneurysm of vertebral artery, and pica goes from the sac. So the only solution here is a flow diverter. And after the deployment, we see that the proximal end moved into the sac of the aneurysm. We had problems. We were fighting for some time, but eventually we managed to place flow diverter and also deployed pipeline stent. Because of the dislocation of the distal end into the sac of the aneurysm. And in case of this kind of aneurysm, we should either use a longer stent, oversize it in length, so that it is fixed well in the vessel, or use more rigid stents. This is the result of pipeline deployment. The long-term result is pretty good. You can see it in 12 months follow-up. The vessels are patent. Another situation, the aneurysm is in right ICA and junction with PCOM, the largest vessels, and the problem is that we cannot change the flow and divert the flow. And flow diverter does not work really well in this case. And on control, we see that aneurysm in 6 months is still open. It's not occluded. We can see recanalization despite good placement of the stent. Maybe we need to follow it for a longer time, and we hope to see some changes later. Summing up, we can say that a P64 stent is exceptionally flexible, even in passing through significant tortuous vessels. And we need to remind that we need distal approach in this case. It provides good flow diverter effect, and the most important advantage is complete control over the stent. We can navigate it, we can retrieve it. And it has, and it is possible to reimplant it, and they have unified size range. As for disadvantages, slight degree of radial force, and it's difficult to pass inside the stent because it can be displaced. So the manipulation should be very delicate. Thank you very much for your attention.